I'm Krishna Madhiwala, a senior at Briana High School, and today we are joined with Dr. Briana Walton, who is a double board certified surgeon in Obstetrics and Gynecology, female pelvic medicine, and reconstructive surgery. She also served as the director of female pelvic medicine and reconstructive surgery at Anne Arundel Medical Center and at the University of Maryland Capital Region Health. She's recognized as an expert in robotic or minimally invasive surgery and treatment of fibroids, urinary incontinence, and pelvic organ prolapse. At AAMC, she helped develop the highest volume robotics program in the state of Maryland while developing pragmatic growth around quality, cost containment, and safety. What inspired you to choose this career path, and what continues to motivate you?
How professional am I tonight? Like, is this laid back, or is this like do you want me to be Dr. Briana, or do you just want me to be Bree?
Could we do Dr. Bree?
Okay, I like the mashup.
Mm-hmm.
Okay. So when I first got to medical school, which I was pretty convinced that that's what I was going to do from first day of college. That was my path. And I was in a pre-med program, and, they basically made us do things to make sure or assure that we were going to go to medical school. But when I arrived at med school, I said, I know one thing, I'm not going to do OBGYN. There's no way I'm going to do that. And so be careful what you think you're going to do, and be careful what you say to other people. It may come back to bite you. So I got some advice pretty early on that I should not express those sentiments to anyone, and that I should just go into every rotation looking for the positive. And so when I did OBGYN, I was pleasantly surprised. I was like, oh, that was not just doing pap smears all day long. That was much more broad than I expected it to be. And so I did another rotation just to make sure I confirmed it. So, the rest is history. Ended up doing OBGYN and then moving forward to other stuff.
Yeah. Did you get to see any labor and deliveries during your rotation? Did that change your decision at all?
So I worked in the day when students were really hands-on. I mean, if you've ever watched a medical TV show and the medical students get to do a bunch of stuff, those were the days. Now it's more observational, and they limit how much hands-on the students can do, which I think is sad, because then folks don't necessarily get a real understanding what it's like to be a physician in that particular discipline. So I was doing deliveries, I was participating in surgery, I was rounding on patients and, telling them their diagnosis. So, labor and delivery definitely had an impact on me, because, the triage area where everybody comes in to be assessed is pretty much run by the junior residents and medical students. And so you see people as soon as they hit the door, and sometimes they hit the door pushing a baby out. So, and there's no time to call a senior person. So you're it. And there's just other things that happen. It's like working in the emergency department, but really centered on female health.
Mm-hmm. And how were you able to choose the right program for your residency? How did you know that the one that you got chosen to was for you, the one that you matched into?
So I trained in Cincinnati, and let's see, at the time I was still engaged, or was I? I don't remember. I wasn't even engaged. I was dating, and I was considering a program in Texas, several programs. And I went back and forth with, where do I want to do? Do I want to go to training where I was from, because I'm from Ohio, or do I want to go to Texas where my then boyfriend at the time was? And I decided to stay in Ohio for a couple reasons. One, it was financially better. In-state tuition. Second, the program I went to had a specific sort of, how would you describe it? More of a really focused, narrow focus to make sure that minority students interviewed the same day. And so there were a lot of people that looked like me where it didn't feel so like it was going to be so isolating. And I think a lot of folks who have had not the best experience in medical school realize it's because they feel isolated, regardless of what it's for, whether it's race, gender, or just social reasons at all. You need someone to help you get through that process. And having that one check really helped me select Cincinnati as the place that I wanted to be.
Yeah. So like that social kind of like your social safety net almost.
Yeah. And it was interesting. One of the women who I interviewed with, it's weird how things work out. She said to me, we were talking and she said, we're going to go to this program and we're going to be friends. I'm like, okay. And it worked out. She ended up being, and I hope you don't mind me telling this now, one of the healthiest things that I did my first and second year was, as her study partner, we knew how important it was to maintain some balance, and eating a good meal, relaxing, socializing was important, but we also knew we had to study. So our take on it was that she would go study and I would cook. And then once dinner was ready, I'd call her and say, okay, come on over, it's time to eat. And then we'd eat together, we'd laugh together. We'd start getting back into our study mode. And then once dinner was done, we'd go study again. And we flip-flop that throughout the week. So at least 3 or 4 times a week, we would, help each other out by preparing a nice meal. So she taught me how to cook too while I was because I came into it with like, this is what I know how to make. And she taught me how to make some different things. So it was kind of fun.
No, that's really cool. I didn't even think about it like that, because it's just a lot of people talk about how med school is just so study, and just it's so draining for you. But like having someone like that and being able to kind of laugh and share a meal, a home cooked meal, even, it just changes it so much.
It doesn't always feel like work, like when that happens. And I think other students started getting jealous, like, why can't we come be your study partners? I'm like, well, if you can cook, show up.
Yeah. And during your med school experience or even your application process, if you had to do it again, what was something that you would have wished that you avoided or didn't do?
Well, I think maybe, because I don't have a lot of regrets, but I think maybe I would have delayed it a little bit. Like I went straight through. And so I would have liked an opportunity to maybe do Peace Corps or some other away experience. I also think that I would consider, especially if I was a student now, I'd actually consider one of the military programs, primarily because you come out debt free and you only have to stay in for 20 years and all your debt's gone and you have a pension. And so from a fiscal standpoint, I think that's a huge help as a physician going through, instead of becoming hundreds of thousands of dollars in debt, or, basically giving that debt to someone else in your family.
Yeah, because financial debt is really, it just comes with, people just see it as med school and debt. They kind of go together and don't really think about that. There's other ways that you could go through med school, maybe be debt free or have a little bit less of debt.
I agree. And then, it all depends on where you are. I went to school in Ohio where housing was very inexpensive. I think I bought our first house for like $25,000 or something like that. And I thought, oh, I'm spending so much money. Like it wasn't a lot. And you come to an area like the DMV and you're paying hundreds and hundreds of thousands of dollars just to live in a sometimes not a great place.
$25,000 is furniture. Yeah, that's not a house. That's maybe a fourth of a house. But kind of going back to your training that you did, what was something that you didn't learn in training, but when you started working in the hospital, that kind of was very apparent to you?
I'll say a couple things. One, from the technical standpoint, right? Like surgical and that sort of thing. There are a lot of things that I do today that I did not learn when I was a resident or even when I was in fellowship. And so that's okay. I think the key is if you're in a surgical discipline, you're coming out with a set of skills and movements that can be translated to procedures. Your knowledge of anatomy really helps you to understand how to perform a procedure. But this box of things that I do, this procedure, that procedure, and why X, Y, and Z, that is not necessarily apropos because technology is changing so much. I think in med school and residency, there was real separation of church and state, right? Like your relationship with patients is very different than what it is when you are their provider, when you have your own practice. Like my connection. So for example, I said my phone might ring because one thing I learned when I was in fellowship, my fellowship director said to me, Briana, I know this may not seem right, but if you operate on somebody, give them your phone number. I said, my personal cell phone? They're like, yeah, give them your cell phone. They probably won't call you, but that connection to you and making them feel protected is going to go so much further than any words that you could say to them.
Yeah.
So I've kept that in mind. I in fact, every patient, I call them in the PACU, in the pre-op area. I tell their partners, especially during COVID when you had less contact with families. So I would FaceTime them and just say, hi, I'm the surgeon. I wanted to meet you ahead of time. I don't want to go into the surgery without knowing you and you knowing me.
Yeah. And do you feel like that helps the patient a lot more before they go in, making them a little bit less nervous before they go in with the procedure?
Yeah, I try to meet them at their need. I'm real flexible about, I have a standard thing that I do, but I also try to read the situation. Sometimes people need you to be something for them. Sometimes they need you to have, okay, put your brave face on, we're going in there. Or sometimes they need you to hold their hand. Sometimes they need you to pray. You just listen to kind of what you think they might need. Ask them if you can do that for them. And it means a lot. I've been surprised about how many people wake up and they don't say, I'm glad the surgery's done. They're like, it meant so much for you, for me, for you to hold my hand or for you to just stand next to me while I was going to sleep. I'll never forget that. Those are the kind of moments that I think they're not just impactful for your particular surgery, but creating lifelong confidence in a patient that this is what a medical experience could look like and maybe should look like.
Do they teach about like the little things in medical school?
Not so much. I think there's just so much coming at you that the relational and there's a quantitative learning that you need to get in medical school. What do we study now? Biochemistry and microbiology and neurophysics and all that stuff. And it's just like you got to get it in your brain. And so the relational or the qualitative aspects of it, it happens, but it's really soft. And I think you perfect it for your own personality later on as you're in residency and certainly if you go to fellowship. But that first 5 years of your own practice, or whether you're working for a hospital, a university, or yourself, you just morphing yourself into who you're going to be for the rest of your life.
Yeah. That's really insightful, actually. I never thought about it like that. Because I mean, I know that in med school, it's a lot of information, just 4 years of just learn, and then go. But the emotional aspect is really important too with the patient.
Yeah, I think that's why I emphasize it's so important that the process of becoming a doctor should not dehumanize you. you need to figure out who
Can we get
you
that in
are.
quotes?
What's that?
Can we get that in quotes?
Oh, I'm here. Oh, that's me. Sorry. Yeah, of course. You know, and it's not original. I've heard other people say it too, but remember, we're training you to think a certain way and react and understand processes and not necessarily get too emotional, but emotions are part of being the human experience.
Yeah, for sure.
So it'll be, a period of time where you maybe it's secondary, but I think outside of medicine, if you're doing something else, you want to make sure you maintain that humanity. What's important to you?
Yeah, 100%. And out of all the cases that you've treated and kind of connected with these patients, what's something that you really frequently saw among women that could have easily been avoided?
Childbirth. I don't know if Pax is on right now, but I think I remember him because Pax and I go back a while, and I think I remember him saying thanks to his mom for birthing him, as he now understands what it's like for an obstetrical experience, or I usually say obstetrical drama and trauma. But I think the key is a lot of American women have become more aware of pelvic floor disorders, my specific discipline. And I like to describe it as the B's, any bowel problems, bladder problems, or bulging of the pelvic organs. That's sort of my world. And most of it is related to obstetrical indications, but it also, from a lifestyle standpoint, anybody who has any chronic increase in intra-abdominal pressure. So somebody coughs all the time from asthma or COPD, or, even interesting, your female paratroopers. I used to work with the military because I was a fellowship, and our fellowship was with Walter Reed. And a lot of our patients that were paratroopers, they had pelvic floor problems because of not necessarily landing, but when the parachutes went back up, it yanked them and kind of tore their pelvic floor. So, just making sure that we are doing a good job of informing women. My mission has been, and this was one of my students actually who rotated with me. We really focused on this, and this has now become my sort of flag that I wave, is we've got to improve patient healthcare literacy. They've got to understand the things so that they can be better advocates for themselves, particularly women, because they are usually the spokesperson for the whole family.
Yeah. And with the pelvic floor disorder that you mentioned, are there any healthy habits or any lifestyle changes that you would recommend so that you can have a healthier lifestyle?
I think so. One of the things that women do specifically is, and this is not anti-feminist or anything like that, but you do need to understand your own body and what the strengths of it are and what the weaknesses are and vulnerabilities. And so I hear a lot of patients talk about doing a lot on their own, moving furniture, picking this up. I didn't have time to wait, so I did it myself. And that not having good pelvic floor contractions and understand how the core, the floor, and the back door, as I usually say, integrate together, and understanding that you need to kind of contract things in order to protect your pelvis. That's one thing that we don't do a great job of when you go to the GYN. And I don't know if any of you have ever experienced a GYN visit, but as a young person, they don't just kind of go in and get your pap smear done and you're gone. So we need to start doing a better job of teaching younger people healthy habits so that they, and to be aware of when changes are happening, because a lot of the changes happen in silence until they're a later stage.
Yeah, so patient advocacy, patient literacy, and just making sure that your posture is good?
Posture is good and an important step. I think not just from the standpoint of the pelvis, but think about how much time we spend in front of computers nowadays, and ergonomically, we are putting our bodies at risk. I mean, from the operating room, I really try to focus on good postures with, not having using my larger muscles, but keeping my shoulders down, my head up, and then using my smaller muscles to manipulate. That's good ergonomic health. But sitting in front of the computer, a lot of folks don't think about that. That was one of the, in fact, I have a presentation coming up soon about wellness and ergonomic. I think, what did I call it? Sit happens. The ergonomic problems of sitting in front of a desk or something like that. And that's a really important aspect, especially also if you think about the population is aging, more people are working later in life, and so their eyesight is different. And so they tend to lean forward, and your head is like a bowling ball on a toothpick, and you're trying to balance it, and you're cantilevering it so that then you cause more cervical neck strain. So just anything, or I would say mechanisms that you can do are really just looking at your setup. I talk about this a lot. I also talk about there's some quick things that you can purchase to help remind you, hey, sit up straight.
Yeah. And for the pelvic floor disorder, are there any particular cases that stood out to you of the pelvic floor disorder, or just in general in your career?
So, it ranges. So here in the United States, most of the women that I typically see are over the age of 55. And their prolapse, or their incontinence, they've been ignoring it for a period of time. In my private practice, I tend to see younger patients who have more sexual dysfunction and want to talk about, well, what's the relationship of what I'm feeling, because things don't feel right, and potentially pelvic floor disorders. Outside of the United States, I've done a lot of medical mission work. Women don't necessarily have access to regular health care, and in some cultures, younger women are marrying and having children in an undeveloped body. So if you're in a country where food is scarce, and you're not, you're 13, that 13-year-old doesn't look like our 13-year-old. They look more like an 11 or a 9-year-old. And they're in a situation where they're, by the age of 12 or 13 or 15 having a baby, that can cause some significant changes to the pelvic floor. And one of the issues that I've dealt with a lot abroad are obstetric fistula, where there are connections between spaces that shouldn't happen, like between the bowel and the vagina, or between the bladder and the vagina, where women are completely incontinent of stool and or urine. So, those are really interesting and sometimes devastating things that can happen to the pelvic floor.
Yeah. And you mentioned that you would treat patients both at your hospital and at the hospital that you worked at and at the private practice that you have. How was the change from working in the hospital to your own private practice?
Well, I still do both. Okay. So, and it looks very similar in terms of what you see on paper, but the experience between me and a patient is much different in that I take a lot more time to just talk about things that the patient is concerned about. I'm getting a good medical history, but I'm leaning more into what is the subjective issue that we're trying to deal with. What's the goal of our interaction, and is this business where I have on the side, is it relevant to your subjective issues?
Yeah. And what made you want to open up your own practice?
I think you saw saw in your questions, which you had like 35,000 questions. I did a master's of art and design, and that changed my perspective. And I do want to spend a little time talking about that because I didn't do that until I was 40 something years old. I think it was in 2015.
I was going to ask you about it, but yeah, go ahead. Sorry.
That's okay. No, I'm sorry. But it's a funny story. The reason I decided to do it, I was on vacation somewhere. I don't remember what. And I think I was just I had really been working really hard in the hospital and I was tired. And I was like, you know what? I could just be a decorator or, an architect. I think I'm going to look into a program that I can be an architect. And then you have to go back to undergrad for that. And I was like, that's not happening. And then I just started being a little more curious, like what else could I do? And I came across Hopkins had a program with Maryland Institute College of Art that you could get a Master's of Fine Art and an MBA. And a lot of doctors have their MBA. And it was a design leadership and it intrigued me. So I called them and, it wasn't quite right for me, but they said, hey, we have this other program because it sounds like you want to be more entrepreneurial and not just in management. And that program really changed my life and my perspective about who I am in medicine. So you may hear other doctors as you guys push through your experiences in your medical school training and residencies, that people are getting a little more grumpy and that they are not necessarily all happy. And I think part of that dissatisfaction has to do with the devaluing of physicians. And one of the things that I learned in art school is that value is subjective, right? Like a painting could be worth $5 or it could be worth $5,000 or $500,000. Who assigns the value? The artist assigns the value. How popular is a song? That's subjective. And so I started thinking of myself as, well, how valuable am I? And what do I have? And how would I put that in terms of medicine? So part of the reason I started my private practice was because I wanted to pull out a part of me that I thought was valuable and protect it from the machine of medicine so that I would continue to have a love for medicine.
Yeah. Yeah, it does. And if you were to ask me personally, I think that you have a very high value. Yeah. But when you went back to school, you already went to medical school, did your undergrad and everything. What was it like going back to school and kind of like
I was 40 something. So I was working full time. I was running a program and a practice and it was humbling. Artists are mean. they tell you what they think of you. You can do the math in a business. My degree is a master's of business in art and design, and so you can do the math part and be fine. That's easy. But you start trying to do a design, and somebody's going to critique you. And then I remember my first project. They're like, "This looks like craft work. This is not art." And so I was so happy that I already had another job that I can lean into and say, okay, well, you're not going to break me down. But a lot of my cohort, they were young. And so this was the only thing they had. And so if somebody broke them down, it was devastating to them. So at least going through it later in life, I think I had more perspective. But it was an experience that I'll never forget. It's been one of the most gratifying experiences that I've had because I think it helps me to see things differently, and that's the beauty of perhaps coming in medicine is that you don't want to always just see things one way. You want to have a vantage point from the patient's perspective, from your peers, from other providers, from the folks that work for you. it really has helped me change the way I think.
Yeah. And kind of going back to what you were saying on healthcare and like the state of mind that people have
Mhm.
when they're as a medical professional, how do you think that the strengths of healthcare as a field are today? And do you think that that's something that could be improved on or?
Well, absolutely. I mean, medicine is about to have a as a discipline a rude awakening, right? I think you guys can appreciate this that the healthcare impact with the pandemic has resulted in a lot of people deciding they don't want to be in healthcare anymore. And so we've lost not just a lot of physicians, but nurses, folks that transport, folks that clean the room, lab techs. And so now you've got less people to provide care. That's one sort of uh-oh. The second is we are having to fill spots with different criteria. Nothing wrong with a physician's assistant or a nurse practitioner, um, but they're not a surgeon. So when you're missing a surgeon and now you replace them with a PA or a MP, there's just going to be a gap. And our patients are going to have to start to understand and my worry is that because Americans are so used to having a certain degree of care, they're going to have to get used to this new delivery system that's heading their way. I think
Yeah.
it's going to be the haves and the have-nots in many years to come.
Yeah, for sure. It's because I know that during the pandemic, there was a lot of talk about travel nurses and
Mhm.
how travel nurses are becoming like they need more travel nurses. And
Well,
yeah,
one of the things that's happening, okay, and you guys have probably already talked about this, is in the hospital setting when there's a deficit, they have to pay people more in order to meet that need. And if you're paying someone twice or three times as much to do a job, and if they stay in their home job, that they don't get as much money, people are leaving their home jobs to go travel. And so they leave a gap where they are, then they go someplace and they're making a lot more money, but that takes away money from everything else in the hospital. So it's complicated and it's going to be messy, and there's nothing else we're going to be able to do because this is the way we had to manage it from the acute standpoint. I don't know how we're going to clean it up and how fast we can clean it up.
yeah. Have you personally had to deal with anyone that you worked with or anyone like nurses, PAs, lab techs that you might work with that left because of the pandemic?
Yeah, quite a few, and more so that I see people changing positions a lot, not necessarily just leaving medicine, but just going to do a different position than what they're doing, so they don't necessarily have as much face to face. That
Yeah.
they like the remote. They want to not have to be in a hospital setting where they would be at risk.
Yeah, for sure. And I do want to kind of take it back before we before we're cut on our time, but I do want to take it back to just some advice that you might have for our viewers, our high schoolers and young adults that are thinking about pursuing medicine. So what advice would you give to someone?
I think, the traditional study hard and all that stuff, you guys, you don't need that advice. You know that's what you have to do. I think sometimes you have to hear the opposite, that you need to don't take yourself so seriously. Have a little more grace and mercy on your transition through this process. Not everybody is going to walk that straight line from high school to college to med school, and that's okay because you're going to potentially have some really interesting experiences that make you better. And that's part of one a life lesson that I had to learn. I'm going to share with you. I was pretty much used to getting whatever I wanted in terms of my matriculation into programs. And so when I applied to fellowship, I and one other person. We were both in line for the fellowship position in Mayo Clinic, and that was in Scottsdale, Arizona, because they had started a new access point instead of being in Minnesota. And for 3 months, they re-interviewed us. They did this, they did, and then ultimately, I didn't get it. And I was completely devastated. I was like, oh my God, what am I going to do? What am I going to do? I've been waiting all this time because all my other colleagues were getting a regular job. And so I was a little bit nervous about what am I going to do now that I don't have a job? And so I started saying, well, what would make me more attractive? What should I do, in order to, get a fellowship the following year? And I started talking to some people about doing research. I wasn't that excited about it, but I thought that was the right thing to do. But, happenstance happens. I would say sometimes there's divine intervention. And one of the people I was rotating with, he decided he was going to move back home. And home was in Boston. And he said to me, Briana, do you want to come be my first fellow? And I was like, well, where are you going back? It's like to Boston. It's with Harvard. I don't know if you would like it there, but, I think you should think about it. And I was like, I don't want to go to Boston. And I realized after, what he offered me, I didn't get Mayo, but oh my God, I'm getting a Harvard fellowship and I'm going to be the first fellow. And now I changed. I was like, I changed my mind. Yes, I want to go. So just allowing things to happen, not necessarily trying to make everything fit into a box. Let things happen for you and to you. Be open. Ask a lot of questions. Tell people what you're looking for. And I think you all, as young people, are better at that than I was when I was a young person. So I don't think you'll be at risk, but I think just taking yourself too seriously is still something that most of us suffer from.
Do you take time for yourself from your busy schedule, and what's something that you do to kind of just decompress from your day-to-day life?
Roller skate.
Yeah.
In fact, it's so funny. I got a text from a physician colleague. He said, hey, Briana, I'm seeing a patient of yours that you operated on so and so many years ago. She said you roller skated to her room for rounds. Is that true? And I said, probably. So, it's just my thing. That's what I like doing. And I like to be able to do it because when I'm roller skating, I can't think of anything else. Like if I do, I'd fall flat on my tush. So, and I can't afford to break anything. So, it's been one of those things. I started doing it in med school, and I met some really interesting people because nobody in my med school class was roller skating. So it was really, really a great experience for me to have a friendship outside of the medical school training.
Yeah, and I think that's really important because a lot of, like you mentioned, no one in your med school class was roller skating. No one was really taking time for themselves because they were just so busy with the study, and just kind of go, go, go.
Yeah.
And and just it's exhausting. So
It's exhausting, and I think there are real mental health issues that happen when you're under that kind of stress. And so you do need something to help you decompress. And again, you are the most important person going through this process, and you got to preserve her because him, because you value yourself. And that is something that a lot of us feel this should be a sacrificial process, and it is in some ways, but there's still a piece of you that you need to maintain.
Yeah, 100%. I totally agree with that. And I know we are coming up on our time right now, but before we do end our interview with you today, I do want to remind all our viewers about the raffle that we have. So please enter and you might get a chance to win a gift card. But with that being said, thank you so much, Dr. Walton, for coming in and interviewing with us today. It was an immense pleasure having you. You're such a fun person. I had so much fun.
Thank you.
Yeah, of course. And it was just really insightful for me, and I'm sure for everyone else that was viewing the interview.
Well, thank you for an opportunity to do this. And Pax, wherever you are in the background, it was good not to see you. I'm just glad you're here and keep doing the great work. This is very inspirational. I wish I would have had something like this when I was kind of going through. To be able to do this together is a really big deal. So great job.
Thank you. And thank you for all the work that you do.